Welcome to Leading Voices in Healthcare and the first in a series of webinars featuring Jim Bajan. Leading Voices in Healthcare, presented by Healthcare Risk Advisors, part of the TDC Group, is where healthcare industry experts share thoughts on the latest trends, data, guidance, and best practices. We are delighted today to present Understanding and Preventing Adverse Events. We'll get started with our program shortly, but just first a few housekeeping items. Please note this session will be recorded and the recording can be accessed by logging back into this event on the Socio platform and clicking the videos icon. Also note that by clicking the icons on the left of your screen, you can review the meeting agenda, read full bios on our speakers, search for other attendees, and access speaker presentations. We encourage you to use the attendee list to connect and privately chat with each other. Our speakers will each give a brief introduction to the topic, and then most of our program will be a discussion during which we welcome your questions. To submit your questions, please use the chat box on the right-hand side. Note that the chat box can be seen by all attendees and is really intended for the use of questions only. If we're not able to get to your question during the event, we'll reach out to you afterwards. Attendance at today's live presentation will also enable viewers to claim CME credit. Please view these instructions for claiming CME credit. You can simply scan the QR code or follow the directions on the screen. We'll show this again at the end of today's webinar as well. So I'm now pleased to introduce Rohit Bala. Rohit is the Chief Clinical and Quality Officer at Stanford Hospital in Stamford, Connecticut. Rohit?
Thank you, David, and thank you. Just wanted to say thank you for the opportunity to participate in today's discussion with my colleagues, Dr. Feldman and Dr. Bajan. We'll go to the first slide, please. So just wanted to start out with a little bit around, as we're talking about patient safety today, we'll probably use some different terms, and just a simple reminder that these terms have different implications in terms of level of harm that we're speaking of, the frequency of occurrence of the different types of events and the nature of events. And wanted to just to set the table a bit, just to point to a very helpful resource that's available from the Agency for Healthcare Research and Quality on their Patient Safety Network, which actually has a glossary or a library of these terms. And so for some of them, which we'll be talking about today, just wanted to point out the distinction in that regard. Adverse events, of course, being injuries caused by medical care, not all of which are due, of course, to error, which is defined there via HRQ as an act of commission or omission, leading to an undesirable outcome or the potential for such an outcome. Near misses being further upstream in terms of opportunities where harm may not have occurred, but may have nearly occurred and didn't because simply of chance. And then perhaps more at the sharp end or the terminal end of the funnel, serious safety events, which we're familiar with, are things that are much more severe in terms of their impact, often involving a deviation from generally accepted practice, but are of course much more rare than near misses, errors, and adverse events. And so we'll talk a bit about these terms and also kind of their practical application, but just wanted to note that there's a real great diversity of event types when we're speaking kind of in the realm of patient safety. Next, please. So I just wanted to start, and I'll talk a little bit more perhaps at the outset about practical considerations. I think many of you who are attending today are in roles where you're kind of scratching your heads and thinking about how to continue to expand and advance patient safety efforts in your organizations and generally. And so the little donut on the bottom is, kind of a little schematic depiction, if you will, of perhaps the role that you and many of us find ourselves in, where you're in a quality and safety type of role, engaged in a number of different activities and trying to really utilize those activities to drive change within the organization, kind of pushing from the in out, if you will. And I'll contrast that in a second with other things that can be done. But in general, when one thinks about what's being done, and I just want to note that healthcare organizations start from an area where patient safety, of course, is common language at healthcare organizations. How it's practiced, of course, which is what we'll talk about, is very different. But at least the notion of patient safety, of course, is very well accepted. And so we think about these kind of domains of analysis and review versus empowerment and culture. We know that we're all involved in what one might call more stereotyped and traditional activities in patient safety, responses to complaints and grievances, required regulatory reporting of predefined adverse events from different regulatory agencies, looking at claims in the risk management area and adjudicating those, all of the attorney requests that come in, reporting adverse events via internal occurrence reporting systems, of course, compliance, and adhering to a litany of standards that we do via accreditation surveys and so forth. As we'll talk about a little bit about, engaging in much more comprehensive analyses of patient safety events, root cause analyses, which many of you are familiar with. And on the empowerment and culture end, there's certainly been progress in this area over the past decade or two. I think some of these things that are listed on the right as recently as 10 to 15 years ago may not be taken for granted, but are things that I think now are hopefully familiar to everyone today, which are, of course, all of the in-services that we do related to adoption of new policies, new technologies, and so forth. Review processes that are done on an annual basis of personnel, revising policy and procedures to promote greater patient safety, the safety culture surveys that we typically do utilizing the HRQ instruments, and huddles that have started at organizations for patient safety to discuss patient safety issues concurrently. And of course, we all have electronic health records now, and so the development of different order sets and modules in the EHRs to promote safety. So these are what I might call more traditional approaches and things that are done from that kind of perhaps managerial orientation of working from the inside out. If you have the next slide, please. So I wanted to contrast that a little bit with work that perhaps we might think of, just sticking with the metaphor a little bit, of being from the outside in. And those are things that perhaps may be a little bit less common. And that would be kind of trying to create an environment in the organization where, as opposed to a core group of quality and safety personnel trying to push patient safety outside to the rest of the organization through those different activities we talked about, this is a bit more of the organization and its operations having patient safety embedded in its day-to-day and hour-to-hour workflows, such that that activity is actually catalyzing and driving a little bit of the quality and safety agenda at the organization, more of an outside-in type of orientation. And I think in that kind of construct, empowerment and culture starts to become much more important than analysis and review. Of course, analysis and review is important, but that empowerment and culture and kind of baking in, if you will, patient safety to the day-to-day becomes very important. So what types of activities am I speaking of? So these would be things like unit-based huddles. So we've talked about leadership huddles. However, unit-based huddles make the huddle process, in addition to making patient safety considerations more concurrent, it distributes them more peripherally across the organization. So groups of people can specifically focus on patient safety on their units on a daily basis. Mock events, so as opposed to waiting for adverse events to occur, simulating potentially catastrophic events to make sure that the right people are there, to make sure that the right things are done. And these involve obviously creating scenarios that are trained upon and rehearsed and so forth. So when the events do occur, they become much more familiar. And often these types of activities are characterized by the development of bundles. So in addition to response times and proper attendance at certain events, also having practice bundles in place that can actually lay out the different steps that need to be taken. Example is listed there, postpartum hemorrhage prevention. So to have a simulation and mock exercise of a postpartum hemorrhage, but also to measure and evaluate adherence to completion of a bundle when such an event would occur. In addition, there are a whole host of programs that can certainly be created to anticipate and improve patient safety. Preoperative surgical optimization is a good example of that, as opposed to focusing on intraoperative and postoperative management of surgical patients. This is more meeting each inpatient surgery or outpatient surgery prior to the procedure, anticipating potential risk by virtue of the patient's risk profile, and managing the events accordingly and taking necessary preventive measures prior to the surgery. In addition, we talk a lot about patient safety officers at an organizational level. Would want to also advocate for the importance of unit-based safety champions, and that those don't have to be formal corporate titles. They can be individual safety champions on the units who are looked at by their peers as experts with reference to the specific area of practice that's being looked at. In the EMR, hopefully we will get to, and we are increasingly get to, where in addition to simply order sets, we are mining our information systems concurrently so that smart decision support is being offered to providers at the point of care related to potential safety events. We'll talk a little bit more about this in discussion perhaps, but one of the most important things would really be this notion of trying to get to the point of promoting successes in identifying safety issues. So I think just colloquially, one thinks of patient safety events as adverse events that are ideally avoided. It's a very different construct and 180 degrees different to try to celebrate actually identifying potentially unsafe situations. In the picture in the bottom of the slide there, we have a slide there from one of our units where we had a celebration on one of the units for the unit that reported the most potentially unsafe situations in a year. So this would be just more of that construct of trying to celebrate identifying potentially unsafe situations so that not only action can be taken, but to promote kind of a collective mindfulness around patient safety. And not to be dismissive in any way about analysis and review, but there are some ways in which I think to move the bar on analysis and review to promote consideration of patient safety and more proactive safety efforts. One is having observational data. I think we all know that if we do record reviews, we tend to find one answer. When we actually observe care, what we see is something different. Having a pipeline to do anonymous reporting to promote more frank and candid feedback. Having goals in place that relate to safety targets for management and staff also promotes a greater cognizance, I think, of safety at an organization. And in our review and adjudication of these events, being able to adopt a fair and just culture mindset, which essentially looks at what a reasonable person would do in similar circumstances and applying that substituted judgment test. Of course, going further upstream by looking, in addition to root cause analyses, doing kind of more mini type of analyses. Apparent cause analyses are a good example of that, where those are more abbreviated analyses that attempt to look at a potential patient safety event and put in place a more rapid fix, if you will, in real time. And finally, this notion of specialized committees. So we often think of organizational safety committees as committees that are, of course, ones that have regulatory reporting responsibilities, occur at an organization-wide level. We're really, I think, now in the phase where we should be thinking more about specialized committees. So, for example, in our behavioral health unit, we now have a patient safety committee that just focuses on behavioral health because we have the benefit of leveraging the unique skill sets and disciplines involved in that type of care to create more quick and pointed solutions, if you will, in that area. So those are some of the things that I would note could potentially be thought of in a more proactive approach. And just wanted to set the table with some of those concepts, and I will turn it back to my colleague, Dr. Feldman, at this point to continue the program.
Great. Thanks so much, Rohit. Appreciate your comments. I'd like to now welcome Jim Bajan. Jim is the founding director of the Center for Healthcare Engineering and Patient Safety, as well as the Center for Risk Analysis Informed Decision Engineering at the University of Michigan. Jim.
Thanks, David. Let me get my screen up here. I think you should be able to see it now. Is that up there for you, David?
Yes, you're good.
Okay. Well, pleasure to be here today. And Rohit's given a great introduction to the various things to think about, and I'll drill down into some of these. So I think the first thing is often good to start at is what is our goal? And you've kind of heard the definition of adverse event. I think it was a good one. So it really comes down to preventing harm to the patient. I mean, it's about prevention. If we only look at issues where we've already had a problem, that means we're learning by hurting people first, which is probably not a desirable way to do it. So the thing would be preventing harm, not closing the barn door after the cow or whatever barnyard animal has left. These are complex problems, and they really do demand a systems-based approach. While certainly you need expertise of people in the various care areas, input from the patients and others, you really have to look broadly, because sometimes there's solutions that don't lie just in the domain or the responsibility of a clinical care provider. There may be other factors involved. So we have to keep ourselves open to the various influences that come to play when you look carefully at an event that has happened or a close call that's happened. It reminds me of Paul Harvey that used to say, and now the rest of the story. And often at first blush, when you look at an outcome or a close call, a good catch, as you find out more about it, you find it's not quite as straightforward as you might have first thought. I think another thing that's important is defining what is blameworthy, and he has touched on the fact of just and fair. We ended up calling it blameworthy, and we said, what is that? That is, we said it's an intentionally unsafe act, and it's where somebody has done something that was purposefully unsafe. That is, they knew it was unsafe and they did it, and there wasn't any mitigating circumstance that occurred that justified doing that. I mean, you always have to weigh what you do and why. But if somebody deliberately does something that is unsafe without any justification, that's not good. So we're looking at intent, and the point is we should judge others by intent. We're looking at systems, not by just the outcome, which is a different issue. And as it play when there comes things like negligence and stuff, that's a matter of what happened. We really need to look at what led up to that, and not just the final action. And that gets to looking at vulnerabilities. If we only look, which is traditionally, and most organizations do this even now, they tend to only look where there's been actually an adverse event that's caused physical harm to the patient. Now, certainly there's a case where something happened, but there are many others that could have happened that didn't. Or how many close calls had occurred or near misses where someone almost was injured or hurt in that way, and it wasn't by a good catch by somebody or just dumb luck. The old saw that, experience is the best teacher. But I remember my father used to tell me it's also the most expensive teacher. And in our case, who pays for the tuition for our education? It's our patient. And that's not really fair. If we're only learning by events after they've occurred and hurt somebody, that's a mighty expensive way to do business. And a lot of patients will be hurt. And if every clinician or every organization has to learn by hurting their own patients, that is really not a good way to go. And we don't tolerate that in other industries. That's what airlines said, after we crash, then we'll decide how to prevent problems. They used to be that way, a half a century ago. It's not like that anymore. It comes down to what to report and to whom. So, and this is tied back to, if we're looking at vulnerabilities, it means we just don't want to have reports of bad events. We want to look at things that could have led to an undesirable event, and understand how do we report and how do we do this in a way that people are willing to do. And I'll touch on that a little bit more in a few moments. But it's really important that we make that clear and how it will be used. Reports should not just be for counting. You always should start with the end in mind. That is, why are we asking for reports? If it's safety, to understand vulnerability, so we can then decide, do we want to mitigate these problems or not? Do we want to eliminate them? What do we want to do? If it's to be graded because you want to get a leapfrog gold medal or whatever, that's a different issue. And you should really think about what the reports are going to be used for, because you might want to have separate systems so there's not a mixed message about what you're doing. Some are for improvement and some are for other reasons. They're distinct and probably should be done in a distinct, well-defined way. Once we determine there's a vulnerability or an undesirable situation, then it's and I put root causes. There's seldom ever one cause. There's usually multiple causes, and we used to call them root causes and underlying contributing factors. Because if you don't look at the many things that contributed, it's usually not one. There's usually a whole chain of events that, when they come together, the confluence of them, and they just happen in just the right, or you could say wrong way, that leads to this undesirable outcome. So without understanding that, then your actions won't deal with the real causes. Because if you just treat the symptom, that doesn't get you there. So you can have whether it's a incorrect medication that the patient gets. Today gives an example. There's a whole host of reasons that could lead to the patient getting the wrong medication. It could have been it was prescribed incorrectly. It could have been the wrong one was actually administered. It could be the patient took the wrong one at home. Well, without knowing the cause, you don't know where to intervene. Where are the actions or the environment in which the care takes place that provides the greatest risk that this could happen? Without knowing that, you often will get foolish or superficial kind of knee-jerk responses that don't really give you the sustainable change you need. So it's really important to look at that, and that gives you sustainable results. If you really look at the broad group of contributors that occur, then you can kind of methodically look at what do we mitigate, how do we mitigate it, how do we measure that we did it, what process do we put in place. We want to get beyond what often is the case where we tell people to be careful. Don't do that again. Well, they didn't want to probably do it to begin with. So tell them to be careful is kind of insulting, and that's probably not the way we want to go. And you heard Rohit talked about culture. Culture is a dependent variable, and it's really that by that I mean it's the sum of what you do, not what you say. Talk is cheap. Culture is, sometimes people will talk about it's how we do things here. It's not necessarily written down. It's what you do. It's the sum total of what you do. In fact, back in '98, we wrote the first cultural survey that became the ARC survey. That was in '98. Then in early 2000s, it became the ARC survey you're familiar with, because we thought culture is important, but it's just one step. You have to understand, what do you do to get that culture that uses these various practices? So what are some of the critical elements? We talked about these, and I'll kind of go back through this again. So it has to be safe for reporters to report. That's from their perspective. And it's close calls and adverse event. It's not just, the bad things. It's also the close calls, because as we said, you'd rather learn there's a problem and correct or mitigate beforehand before anyone's hurt. But if people feel like if they report, they'll be embarrassed, humiliated, which is the single biggest reason, not because they're going to be punished, but and there's plenty of data on this, it's that they'll be embarrassed, humiliated, or their coworkers will be, or their institution will be. That's a disincentive. So you have to think about how you report, what you report, and how is that report done. And there's many things we'll probably go to in discussion about that. You also have to understand, once you become aware of a vulnerability, you should have a prioritization methodology that's explicit and transparent, and it should be risk-based. And everyone should know it. They should know it outside your organization. The press should know it. Your patient rights groups should know it. All your employees should know it. So everybody understands why you do things, that there's a reason. It's not based on personal whim or for small political reasons. So I think that's really important. What's blameworthy? You can go to the Justing again. We talked about that. And that way you get away from the question that often people ask is, whose fault is that? And I would say that's a good measure of culture. If you go to an event review and somebody asks early on, whose fault is that? And I call fault the F word in medicine, then they don't understand it. The culture is bad. If you go to really good organizations, they don't ask that question. They ask the 3 W's. What happened? Why did it happen? And what are we going to do to prevent it again? And that's true in healthcare, though it's a big problem there. It used to be true in aviation in the old days. And I can tell you, I've done both space shuttle accident investigations. I remember on one of them, as we met right after the Columbia investigation, one of the other generals on it said, hey, let's get straight. The reason we're here is not whose fault is it. It's how we, make sure we understood what happened and prevent it in the future. And everybody looks at each other like, no kidding. That's the way we've done business for decades. I wish that were true in healthcare. Still, people ask whose fault is that? And that is not a question that should happen early on at all, because it's not about fault unless you think it's an intentionally unsafe act. And that'll come out when you look at the contributing factors. You want to use a human factors engineering tool and approach to this. So you look at what are the various things that affect behavior in a positive or negative way. How do we design our equipment? How do we design our processes? It goes into everything to work hours, shift management, fatigue management, usability of hardware. Do we buy a new IV pump, for example, that works in a different way than the last one? Well, then you might want to think about, is that a good idea? Or how are you going to do more than just give them in-service to make sure that they don't use the same approach that they used to the previous pump they'd used for 10 years? That's a problem. Even if it's better in other ways, you might introduce problems that a user will have, and it's because they're human, not because they're doing anything wrong. And then the question is, how do you make sure what you find actually gets acted on? And I think this is really important. It's about management. You want to have, at the top level of management, I mean the top level, the CEO level, that they concur or not concur with any recommendation that comes out of an event analysis. So if the people that look into it know more about this than anybody now, and have done a really thorough event analysis, say, well, this is what happened, this is why it happened, this is what we think we need to do to mitigate it, by when, by whom. The managements either say, I concur, and if they concur, they supply the resources necessary to do that. Or if they don't concur, they give the rationale why not, so there can be some meaningful discussion, not just you're wrong, but, oh, this is the reason, does that make sense? And then they own it. So that means that they don't give unfunded mandates to people, that they go give them the resources to get it done. Because if they don't, you're not going to get where you need to go. And then you want to have feedback. You want to have a constant feedback loop where you look at, and I see I should get feedback here that we missed the typo on this very slide, that you have transparency internally and externally to look at what you did and why. So everybody understands why things are being done. So they don't invent reasons, but they understand why. So there can be meaningful feedback and communication to make things better on a continual basis. And finally, that our patient safety duties ought to be dedicated duties, that we don't just have people do it in their spare time. This is important if we're going to have continuous improvement to constantly make things better, because even if we have a great solution today, the world is constantly changing. What we understand about diseases and human physiology, what treatments are available, mitigating things we can do, financial constraints, et cetera, they're all important. And they change, and that might make what was a great solution yesterday not a good one tomorrow. And to ask people to do that in their spare time kind of sets you up for failure. And we really want to avoid putting ourselves behind the eight ball in ways like that. So I think by thinking about things like this helps us take adverse events or vulnerabilities are discovered and actually proactively deal with them in a way that makes sense. Finally, this is not about errors. I think errors is not the thing we should talk about. Errors are a subset. Errors imply people did them, which forces people to start thinking about whose fault is that. That's not what we want to do. Reports for safety are not for counting. That is not the objective. It's identify vulnerabilities. You want to hope your reports increase because there's things happening all the time. They should never go down. You find more and more. You can decide what you act on, but you want to make sure you're learning as much as possible. And you want to have analysis, action, and feedback, especially feedback are the keys to keep this going. Because if people spend the time and put themselves at an inconvenience of reporting or vulnerability of embarrassment, humiliation, or worse, they're not going to do it. It's an IQ test. They won't do it if they think it's not going to make things better. So this is about prevention. It's not about punishment. It's about how do we prevent things from happening. We can't untoll the bell. We want to go and say, how do we prevent these things from happening in the future? And this ends up with culture change, but that takes time. And we have to understand it will take time, but it doesn't take forever. So finally, I would just say you have to think safety is the foundation of which quality is built. If you're not safe, then quality doesn't even exist. And I'll leave it there and go to discussion. So back to you, David.
Great. Thanks so much, Jim. So now we've heard some introductory remarks from both of our experts. Let's get into some details, right? Let's really probe a little bit. You've talked about some definitions, Rohit and Jim, and I think for many in our audience, this is almost like drinking from a fire hose. There is so much out there, right? We've talked about close calls and near misses, which the first question is that an adverse event, a close call? And if so, there's a lot of them, and you've said this yourself, in institutions that really get this. How does somebody starting down this road figure out, where do we start on all this? All this stuff is coming at you. How do you logically separate all this out so that you don't get overwhelmed? And I know a lot of folks in hospitals today, especially with COVID, are overwhelmed with these things. What's a logical way to start down this road? What do you both think?
Well, I can start maybe a little bit of the discussion. I think that I would still, and I think to David, your point, it is a potentially large universe, but I think now more than ever, it is very important to stay open-ended about it. I think as technology progresses and healthcare becomes more complex, it's very important for us to have a broad-based orientation. If you look at the kind of component of adverse event definitions that relate to the kind of undesirable experience, just think of using electronic health records. If a patient were to receive a lab result and discover it themselves, a very negative result, if you will, through their portal, and not have had the opportunity to speak to their physician, I would consider that an undesirable experience and something that's worth looking at. That per se may not have caused physical harm, but it's still very important in this day and age to be open to think about those things. And I think that's where, as a starting point, the different conventions and the kind of stereotype reporting that are done can be of help to start, practically speaking, and then building out from that. Not that it is the end all be all, but your own occurrence reporting system is going to have a wealth and a reservoir of information to start from. But those are some manageable areas to start, and also areas that one of the values of the occurrence reporting system is that it is the voice to some degree of the staff. Someone at the end of the day felt the need to make note of an event or a situation that was potentially unsafe, and it's really incumbent upon organizational leadership to hear that voice, to adjudicate it, and as Jim mentioned, to start to get into the feedback component of it.
Yeah, I love what you said about the patient's perspective, right? Putting yourself in the patient's shoes. What are they going to think when they're faced with this? It's very, very hard sometimes to get so caught up in what we're doing. And look, I even know as a patient myself, medicine is complex, and I have a working knowledge that's far greater than the average patient. So putting yourself in their shoes is so key. Jim, thoughts?
I would just build on that. I think, Rohit, I think what you both said is correct. I think there are tools out there. In fact, if you look, and maybe we'll talk about it later, but the thing that the National Patient Safety Foundation sponsored, or did, that TDC sponsored a while ago with the RCA Squared, in that is a whole complete system that talks about these things. What is blameworthy, the just thing? How do you triage the reports you get, right? You want people to report. You don't want them to self-select. You don't want people to say, well, I don't think this happens much, I'm not going to report it. You want at the institutional level to know as much as they can report, and then by telling them and putting out, and that one is called the SAC score, the Safety Assessment Code. It's been used for 2 decades in this country and around the world. It's been used, literally millions of times by now. It lets people have a very transparent way in which you look at what's important, why it's important, so you can explain why. And that just sets the hurdle. If you cross that, you're going to look at it. Doesn't mean you can't do more, but you can't do less. And you'll see, if you look at your cultural surveys in many organizations, people sometimes, you'll see that there's a non-insignificant percentage of the people that work in your organization that feel like things sometimes get covered up or don't get the attention they believe they need. And they perceive it's because of people playing favorites or other things. And usually it's not the case. By having a concrete, explicit criteria everybody can look at, and then you live by that, there's consistency, and that develops more trust in people willing to do that. And this becomes the bundle sort of that Rohit talked about, because that goes in what is blameworthy. How do you deal with that? Because then they say, oh, if I report, am I going to be punished or not? I mean, we've seen latest things in the news over the last couple of months about stuff that was poorly handled at the institutional level, where it led to really undesirable outcomes because they didn't have a good system and didn't execute it. They didn't look at it from a systems way. It became a blame thing, which is exactly the antithesis of what you would want. That's preventable.
Yeah. Let's go back to event reporting. And we've gotten some comments in the chat about this. It can seem a little bit overwhelming when you get all these things coming in. And most hospitals now are using some kind of electronic adverse event reporting system, but it is voluntary, right? What's your view on those compared to, are there ways to capture, I don't know, can we capture everything? Do we want to capture everything? How do we, justify all this stuff?
Can I take a crack at that? I mean, I got asked this. It was the very first congressional hearing on patient safety back in January of 2000, chaired by our own Spector, and I was the witness for that. And he asked the question. He says, well, I think there should be mandatory reporting. And he says, I understand you don't think that's true, Dr. Beige. And I go, well, he says, well, it's right here in the New York Times this morning. Have you read the New York Times? And Robert Pear had quoted me. And I said, well, I don't remember, what was that, Robert Pear? And he goes, yeah. He goes, it says here that you thought it would have a chilling effect on patient safety. And I said, well, when I met with Robert Pear, he didn't take any notes the whole time we spoke. So I don't think that's a direct quote. I wish I had said it so articulately, but I believe that. I said, in the end, and I learned it from Charlie Billings, who set up the aviation safety reporting system. In the end, all reporting is voluntary. People report what they choose to report. If they don't report because they're afraid they're going to be unjustly treated, punished, their organization is going to be suffer disadvantage or whatever, then they don't report. They weigh what happens if I report versus not. If they think they report and it goes into a black hole, why would they? If they think they're going to be punished, right? So you want it to be that they report because they want to. And how do you do that? They're not going to get blamed. It's not going to be treated unfairly. And you're going to fix something. You're not just going to publish reports of reports. That's not useful. So if you do that, you can set that up. And aviation went through this back in the 70s. They didn't always do it either, but they did. And it changed the world for aviation. And healthcare has done this in some areas. Most people aren't doing it, but it can be done. But if you get reports, it's for you to decide at a leadership level what you look at. You don't have to just rely on reports. You can look at other data we have, infection rates, other stuff. And we even went through, when I was at the VA, people said, well, do you have to be a full-time employee to report? And I go, are you kidding me? I don't care if the FedEx guy's walking through the lobby and see something. It's for me to decide if I want to look into it, but I want to deny myself of somebody telling me there's a problem. Would I say the patient can't tell me something? If they perceive something's wrong, it doesn't mean it's true, but then look into it and find out, right? And I can tell you, having handled, running the biggest system in the world that looked at this, it took, on the average, a patient safety manager each day to triage, use these prioritization tools every day, 20 minutes for all the reports, 20 minutes. We're the most highly reporting organization in the world, 20 minutes time to do it. So when people say it takes too much time, that is baloney. Absolute baloney.
Rohit, you mentioned this Great Catch program, and one of the questions from our audience is about feedback, right? So part of encouraging people to report is they have the sense that you're doing something about it. And you just said you may not act on all of them. Well, certainly a great catch, that's an easy one to reward people, and people feel like, gee, I'm so glad I said something. But how do you give feedback to reporters? Rohit, any other thoughts besides this Great Catch program on how you might do that?
Yeah, I mean, I think that a couple things on that. One is that it's very important to when one recognizes the event. What we try to also do is to connect it to how it was beneficial to not only the immediate patient family situation, but how it will likely be beneficial for the future. So that real-time feedback, as opposed to simply feedback alone, I think is very important. The other thing, and it's a simple thing, but an actual token of acknowledgement, whether it's a small gift card or a bouquet of flowers or something like that, and we could probably snicker a little bit about how simple that is, but the physical acknowledgement of it becomes very important, because I think it really validates this notion, which is very simple conceptually to say, which is to celebrating a great catch, but it's very much the opposite and antithetical to the way we've always thought, which is, a person might come to work saying, I hope to not do anything bad today. It's a very different statement to come to work and say, I hope to make healthcare safer, or this a better place to work and safer for our patients today. And it's really only through some of those physical acknowledgments and actually publicly recognizing people that people kind of, it's not so much necessarily about that person who made the great catch. It might be more about the 25 people who didn't, who are watching and kind of taking notes, who may not be early adopters, but then come into the tent a little bit later. And that's, I think, how things become a bit more pervasive. So I would put in a strong vote for, leadership really thinking very carefully about how they actually validate and provide feedback. That becomes very important. The publicity of it, the connection to the benefit from a safety point of view.
Yeah, it's interesting. I remember reading a number of years ago, I think it was an Eisenberg Award winner mentioned that as a senior leader, I think a CEO even, that he made it his business every month to make sure he wrote 5 or something like that handwritten letters to staff, which takes no time. Who gets a handwritten letter anymore of anything, right? And this is, I think, 10 years ago. Now there's nothing handwritten, but imagine getting a handwritten letter from your CEO thanking you for reporting something. It costs nothing, literally, in time and effort. And it's so much more meaningful than so many other things, right? I think that's powerful. Jim?
Well, I can't agree with you more. I mean, giving feedback, people want to know that things will get better. I mean, one of the things you see from the cultural surveys is people say, I report and it never gets fixed. Now, they don't know it gets fixed. Sometimes it does, but that's on leadership. If you fix something, be transparent. We had a problem and it got fixed. It was because somebody, don't even use their name, somebody in housekeeping saw that, or whatever. So things are get fixed. One thing we did, and we hardwired into our system over 20 years ago, is when we would finish doing a root cause analysis, right, a multidisciplinary root cause analysis, we would go back to the reporters before we went to the CEO, because only the CEO at each hospital would say, I concur on a line on each action. And if they concurred, it would be done with that, with the resources. And if they didn't concur, they had to say, why not? And then it would circle back to, they would revise it till they would concur, right? That was all transparent. But before they did that, they would go back to the reporters and they say, here are the root cause contributing factors. Do you agree? To the people that reported it. If they didn't agree, that would go in, either the team would say, oh, I missed this, we should change, or they'd say, you know what, we don't agree, but they would tell them that, right? But it would be a dissenting opinion in the final report. Similarly with the actions. Well, we went then and surveyed, this is over 20 years ago, we went to some of our regions and we knew who didn't concur, right? When they talked to the report, they said, I don't think that's right. We surveyed them to say, knowing that we did not concur with their modification of the action or the cause. And one of the questions, we asked a couple questions. One was, do you think this is worthwhile reporting this? And would you participate in the future? Over 95% said yes to both of those. And they were the people that weren't concurred with.
Wow.
And when we went to do that, people were saying, boy, don't you think you're putting a gun to your head? People are going to say, I hate your guts. And I said, well, this is a system we ought to understand, right? And it showed that we, at a top level, maybe didn't give the people enough credit. Right. The people were adults. They understood. They didn't, because we didn't just say no. We'd say, here's why we don't agree with your thing. So it was rationale, not just I'm the boss and you're not. And they go, okay, I realize somebody has to make a decision. That was hugely great for morale. If you look at our cultural survey things, we were way at the top all the time because of that transparency. And we did it all the time. And it took almost no time to do that. And it also made sure that when you went to talk to the boss, you didn't have somebody come later and say, what are they talking about? And then you feel like you're stupid and didn't get, because you want the right answer. You don't want to be right. You want to have a successful solution.
Yeah. And David,
Go ahead, Ray, sorry.
One point I just wanted to add to Jim's point that was also on, as we're talking about the reporting systems, is just, and we can say a lot about the pluses and minuses of occurrence reporting systems, but the importance of them in terms of being able to systematically identify kind of prevalent safety issues, for better or worse, those systems do become very important. So if you ask yourself, what care area in our organization is the area we have to kind of prioritize, and you're sitting there on 100 occurrence reports, well, if 70 came from the operating room, that actually means something. That means that you're thinking about your operating room, perhaps. If you're trying to identify what the most prevalent medication type issue is, and you're looking at 50 medication occurrence reports and 40 relate to anticoagulants, that may have implications for where you should prioritize. So I just offer that as just for consideration, is that it does allow for some kind of systematic evaluation of what are the most prevalent issues.
Could I add something, Rohit? I mean, I think you bring up a really good point. I mean, the fact is that reports are just prevalences of reports, not of what actually happened. And you got to remember that. So I certainly agree that if I looked and I said, like as the example you gave, oh, there were 70 in the OR, I certainly want to look there. I mean, absolutely. But you shouldn't necessarily think that's where the biggest problem is. That's where the biggest problem has been reported. And it could be because there's a better culture, or it could be a whole bunch of reasons, or they think they won't get punished there in the other place. And I'll give you a classic example that changed how the whole world works now. Back in 2005, we had one report of somebody getting an overdose of benzocaine, okay? Topical anesthetic that nobody should be using anymore. Just put that out there. We had one person, right? And they had got methylhemolymia, right? They did not arrest, but we did it. You have to, and we found it because when they reversed it, they did it with methylene blue, which is the antidote, right? And they overdosed them with the methylene blue, so they turn blue, and you get methylhemolymia again, and they had to have an exchange transfusion. That's how we saw it. Well, we looked into it. I said, well, how is it that people are using? I was in anesthesia after I was in surgery. People would use Hurricane, right? And I'd say, well, how much do you spray? And people go, as much as I need. Well, you know what the toxic dose of Hurricane is? How long? More than 1 second. And I bet there's a lot of people on this call that have used it more than 1 second. I would say they wait till they get, David, you're a plastic surgeon, they're getting repetitive, they're getting carpal tunnel because they're spraying so much, right? And they did it. So we looked into it. And then we went out and proactively talked to people, right? And I'm talking to people in the ED, and he goes, oh, and he tells me, oh, I know the antidote. And he tells them the antidote using methylene blue for using Hurricane. That's a problem. When people off the top of your head can tell you the antidote for overdose, that is not a good thing, right? Yeah. And we looked out proactively, and it was happening everywhere. So we said, oh, we should use lidocaine because it was in a reference incorrectly in the literature back in the 50s that it causes methylhemolymia, which it does not. Right. So we ended up banning it. Finally the FDA said, well, we know it, but we really don't want to make a big deal about it. They basically said you shouldn't use it. And we know of cases, one of the New York hospitals, I was there giving them grand rounds, and they had a death in an 18-year-old co-ec that came in for an esophageal, they were just taking samples at lunch, for $15 and killed her with hurricane, right? And this is something that hid in plain sight for years. And the fact is your pulse ox will go to 85 and stay there. So you keep looking and going, I wonder why I can't resuscitate him. The pulse ox is only 85 and they could have zero oxygen saturation. I mean, there's an example of you want to do both. I think
that was one report, Jim.
that was one report. And when we looked in, we said, just our professor, I remember the analyst said, hey, look, read this. And I read, I go, God almighty. I said, let's start calling around. And we did the prospective thing to look observationally, as you pointed out on your slide. And we said, this is happening all the time. And people have been inured to just accepting it. And we shouldn't be doing that at all. So I think they want to do both.
Yeah, that makes sense. I want to get back to this idea. And I know, Jim, you don't like the term near miss. You prefer close call. But let's talk. Fair enough. And I think you and I have talked before that in your mind, if you had a choice between reporting an actual event or a close call, you'd rather hear more about the close calls, right? So do either of you have examples of how you've been able to study close calls and actually reduce events as a result of that? Rohit, I think.
Sure. I probably mentioned, so if we look at patient safety, I know, we had, an event once after a cardiac procedure where sometimes after open heart procedures, you have to have temporary myocardial wires where, it gets very complicated with the number of leads and tubes and so forth. And the leads were inadvertently hooked up following the procedure incorrectly, which did not cause any harm. It was self-discovered before the patient left the OR. And we kind of sat back and said, whoa, if that could happen in this kind of fairly routine case, just as what Jim was saying, this could be the tip of the iceberg. And what we found was, in fact, that we didn't really have a standardized process. And that led to, for the pacing equipment around the procedure, for there to be standardization of the packets, relabeling when the leads were being hooked up, instead of them being hooked up quietly by a member of the team who was available. There was one designated person, and they would audibly confirm that they were connecting the correct leads. And this was all based on a near miss, no harm occurred or anything like that, but it was just a simple self-recognition that something happened. Surgical site infections, to use a much more common example, perhaps for the audience, we as I'm sure many of the participants in today's call have seen that, you do your timeouts, you give antibiotics within an hour, you give the correct antibiotic. That's not the end all be all for surgical site infection prevention. We found that when we did direct observation of different types of cases, that there were lots of opportunities. And we were kind of in this situation where, from a purely compliance and regulatory point of view, there were no other steps that we had to comply with. We were doing fine on the standard measures and we were doing our timeouts, but we realized it might be beneficial to actually have procedure specific bundles. So we defined pre-op, intra-op, and post-op steps that were specific to a colon procedure, a hysterectomy procedure. And what we found when we looked at our rates over time was that we kind of hit a leveling, a decrease and then a leveling when we were adhering to conventional measures. But we had not really a voltage drop, but a further reduction when we engage in these procedure-specific bundles. And that was simply from just kind of doing direct observation, scratching our heads, not having any kind of regulatory prod or anything like that to do something, but to say, how can we take the next step and be more proactive?
And close calls. Jim?
I mean, there's many. I mean, I'll point out one. We had a call from a person that processed scopes, right? We're talking about, an SPD. And they were looking at it, and they saw, wait a minute, they went to order a replacement connector, that flushes one of the channels, and realizes they worked there 3 years. They've been trained by their predecessor. It was the wrong connector. They're using Y instead of a straight through, right? So we immediately had to notify thousands of patients. We went out and said to the press right off the bat, this had happened. And then we gave the guy an award. The secretary flew out to the West Coast unannounced to go to this remote clinic. And we said that he had the courage to speak up and said, he realized for 3 years he'd been doing it wrong, only found it out because, we saw this. Now, we didn't have a big infection outbreak, but it went into how these things were designed. It changed how all that was done for the whole industry, all because we had one of the technicians working there They understood what they were, thought they understood what they were doing, and we had inadequate training, as it turned out, and we used the wrong stinking equipment the wrong way. But because people weren't afraid to speak up. You had that culture. They looked at it and they just said, "Hey, I'm going to report it because that's what we do, and let's figure out how to fix it." It changed not just how we did it in the VA, how everybody did, and how the manufacturers did, and how the FDA looked at it after that. So there's a whole host of those. But if you don't have a place where people think that their reports make a difference, that you welcome them, that they're not going to be punished for doing stuff, it's by their intent, not by the actual outcome. Different from what legal liability is. They're different. They're not the same thing.
Yes.
You have to be careful about that. And I think it has to be thoughtful. You can't, because it's hard to disabuse people. If you have a bad rollout and somebody perceives that you thought they weren't going to get any grief and they did, then they feel like I was lied to. I was stupid, and it's like, shame on me. You can't fool me twice. I mean, you got to really do it right the first time and really think it through. But I think we have the advantage now. These things have been done for 2 decades. There's a lot of good information about how to do it. You don't have to just make it up.
I want to focus a little bit on prevention, right? And how do we deal with these things? And I've always been sort of the mind in a sort of simple way that when we look at healthcare culture and a healthcare environment, you've got 2 things you can change: the people and the system they work in, right? So we know that we try all the time with crew resource management, and Jim, you've done a lot of work in this space, right? We know that from years ago about how we get people to work better together. And then you mentioned in your initial talk, Jim, about the system itself. How do we create things to keep people from making mistakes? Because humans are always going to make mistakes. If you think about those 2 areas, any place you would suggest somebody focus on if they had to pick one place to start? I mean, you obviously need it all, but where would you start in the I like to call this creating a culture of safety, where you address the teams and the system around them?
Well, let me take a quick crack at it, right?
Sure.
I mentioned human factors engineering. I think places that have their act together will actually have somebody with human factors engineering training in their hospital. In a big hospital, if you don't, then you're kind of clueless. Now, you don't necessarily have to have a degree in it, but you should have some decent training, and you can get that. An example is, look at, like, people complain about the EHR or about equipment like an IV pump. If you're getting big time pushback by the clinicians or the users after it's in, that shows you don't know what you're doing at your place. So we partnered with, using the federal acquisition regulations. I became a semi-expert in that, going with our procurement guys and saying, when we're going to buy something, whether it be a monitor, an EHR, a scope, we should, one, say, what does the clinician need? And don't have the clinician tell you, oh, I want the blue one that goes beep. That's great Monty Python thing. You should look up on YouTube. It was made back in the 80s. It's still as true today as it was in the 80s. But, ask say if it's a surgeon, what do you want this for? Don't tell me you want a set of hemostats with gold handles. I don't think gold handles make a difference, right? Tell me what you want it to do. So then have your biomedical engineers, other people look at it and come back and say, oh, here's things that will do what I think you want to do. Have them evaluate it and get the one that is easiest to clean, because we've done a lot of this. There's instruments that are really easily to clean well, and some that are virtually impossible. And they work the same from the clinician standpoint. So why would you buy, and this is with rongeurs, we had our neurosurgeons using rongeurs that were almost impossible to clean well. And we met with them and they said, if you change our rongeurs, we'll resign. So we changed them anyway. And we changed them and we put them there for a month, and we had a separate pack with their old rongeurs there. We told all the circulators are there, give them these rongeurs. So a month goes by and they said, wow, we haven't had any bioburden contamination in a month. This is great. What did you do? What did you tell the people in Central Sterile Supply? I said, we told them to use these new rongeurs, and you've been using the new ones you said you're going to resign about for 30 days now. They go, really? Now I'm not saying you should always do that, but the point was, give them the tool to do what they want to do. Yeah. And it takes other people. It's not just clinicians. It's, right. It's not always the cheapest one. You want one that gives you the best value. So you have to look at, is it easier to clean? Do you have bioburden? Does it stay sharper longer? Can it be sharpened? But you buy your EHR, if you have an EHR come in and people say it doesn't work right, there's a lot of problems. Some of it's training. Some of it you bought a crappy EHR, and that should have been done beforehand. And we often don't do that. And that's a systems thing to get everybody involved, not just people in the C-suite, people in procurement, people all up and down the line.
Makes sense, Rohit.
David, I think, and you've spoken of this dichotomy between people and systems. And I would just say that in terms of that relationship, one of the, I think, best things that folks can do is to try to promote the people owning and making the systems better. So to kind of actually erase the dichotomy, because you often hear that as, that the people or the teams are recipients of patient safety interventions or improvements. You might hear they changed the system so this won't happen again. Well, who's they? That to some extent represents, probably not the best thinking. It would be much better to say we changed the system to try to make it safer. And so I think there's a nice comment in the chat, which makes a note of that. Like when we do these apparent cause analyses, we've tried to involve the actual team members in the fix. So that's a natural extension of a unit-based huddle to say, oh, well, we had an unsafe situation today on the unit. It's not so much just to be the problem pointer outer. It's also say, okay, well, let's maybe try to work on this over the next month and to see how we can maybe fix this and put that in place. So that kind of empowerment, I think, becomes very important to kind of erase that dichotomy.
Yeah. And we did that. Our hospitals did that probably 10 years ago around retained surgical items. We got a group of surgeons, nurses, and anesthesiologists together and said, look, we've got these things, and counting is just, the best nurses in the world are going to miscount, right? We know this. When you have a retained sponge, the patient comes back 2 weeks later, first thing they do, look at the op report. And what does the op report say? The count's correct 80% of the time. Why? They miscounted.
Right.
So we adopted radio frequency, right? All of our hospitals now, we talk to medical students, say, how do you prevent retained? Oh, we wand. Who even says that anymore? Right? We wand. Well, we count and we detect with the wand. So we just published in the Journal of the American College of Surgeons, 10 years worth of experience, almost 1 million operations, significant reductions in retained surgical items. And we've seen fewer malpractice, obviously, a case of result. There's a small number of them, but even those have gone down. But that's, what they call an engineering, Jim, right? Pants over vest, depth of defense. So you've got people counting and you've got a machine detecting. And if I'm having an operation, that's the kind of hospital I want to go to, right? So we have a few minutes left, and I want to make sure each of you have a chance to, what would you say to somebody just starting out? What's the most important thing that people should keep in mind when they go down this safety journey and when it comes to events, understanding these events and then preventing them?
I started the discussion really with what folks can do as leaders and managers, and I would conclude with that I think it's very important to people really see their role and how impactful it can be, leading by example, as well as working directly with teams to kind of democratize the patient safety process. The more that our head of risk at our organization, we have 3,000 employees, and she has an expression, we have 3,000 patient safety managers. And that's really, I think, what one should strive for is not an us and then dynamic, that kind of traditional approach within an organization that I started with, but a more democratized, kind of more distributed ownership approach, if you will, to patient safety. The more that managers and leaders can work to achieve that, which may not be truly perfectly achievable, but to continue to strive for that, I think, helps better the organization and its culture.
Yeah, it really speaks to, rather than having it as an initiative, it's just part of what we do, right? All 3,000 of us are invested in this. Jim, final thoughts?
Yeah, I would agree. The way we approached it, and it's like that, we made it like a fractal. We said, you look at it at the highest level, there's somebody safety that's the CEO, and it goes all the way down to the unit. And, you have your own span of control. We use some basic tools. How we do it, the people up the chain can help, like a servant leadership model, help the people below. And that way the people at different levels, it's not, those safety or quality people are doing it. No, that's not how it works. You're part of it. Any investigation, we always did multidisciplinary. In fact, we wouldn't let people be in another root cause analysis until everybody else had been on one. And it didn't matter whether you were in the C-suite or you were in a loading dock. And we always had one person that wasn't clinical. Always one person wasn't clinical. In the beginning, people said, oh, why is that? I can give you examples of it was the person that wasn't clinical actually identified the crux of the problem. And that started saying, oh, it's a system. You need to have these different people. And that helped you to proselytize. Because when they went back to their unit, it wasn't they heard about it. They said, oh, I was on that. It really was run well. We came with a good solution. So it wasn't like, oh, it's those guys that don't have a clue. It's people that they know. And then that became the way it always got done. And I can tell you, when I go to hospitals, people would stop me. They wanted to show me the RCA team they were on and the thing that was changed in the organization where they worked. They were proud of it. They said, wow, I made a difference. So when they came there, they weren't sleepwalking. They were saying, this is my place and I want it to be better, not just I'm a faceless cog in the machine and nobody cares. I
Yeah.
mean, it changed everything. It changed our retention. Our retention went way up. Our turnover went way down.
That's great. It's about us, right? And you both said this. It's not them, it's us. It's all us. Really terrific. Wonderful. Thank you so much, Rohit and Jim. Really appreciate you joining us today. We so much appreciate your insights and your expertise, and I look forward to hearing more from you, I'm sure, in the future. So thank you. This brings our webinar to a close. We hope you've enjoyed today's presentation. Special thanks again to our guest host, Jim Bajan, and our guest speaker, Rohit Bala. As a reminder, to obtain CME credits, please see the information on your screen. Again, scanning the QR code is an easy way to get the link, but you can also follow the instructions on your screen, and you'll see these in the Socio platform as well. We are planning the next in our series of webinars with Jim as part of the Leading Voices in Healthcare series. We've secured 12 noon on July 28th. Put it in your calendars, when Jim will be joined by Roseanne Rosso, Vice President and Chief Nursing Officer at New York Presbyterian Weill Cornell Medical Center here in New York City. The topic for that session will be engaging the C-suite in safety and quality. Look for more information about this and other events on our website, thetdcgroup.com. We look forward to seeing and hearing from you soon. Have a great day.